Thank you.
Yeah, thank you very much. Thank you, Edward. I think he has covered most of the thing. So, from pre-hospital initial management and whatever. I'm Alan. We are just going to discuss a little bit about pre-hospital and initial management. And these are some of the learning objectives that we are going to go through. So we see the importance. All of this Edward has just tried to go in details, but we see some pre-hospital and initial management, and also look at when you are in the resources limited, what can you do? The burden also has talked about it, but the high incidence of road traffic injuries actually that we are having, it's very crucial. When you go in our wards here in this hospital where we are, more than 60% of the patients you will see they are having open fractures, and the complications, infection, limb loss, but also you can see other things like a high level of disability, and most of them, they are really very young. It's why I think this workshop is very, very important when we are just looking at how we can decrease all of these disabilities and complications to also to gain some economical loss that we are losing all the time. So this, it's all of the management that Edward has talked about, but for me, I will be focusing on the pre-hospital and the initial management. So the pathophysiology also, we all know it. And for the goals of pre-hospital, it's to stabilize the patient, because of the open fractures. They are not only the limb injuries, but they are arising from high energy, and you to prevent further injuries and the contamination. So sometimes when it happens in the rural area and whatever, the management at the initial one is not really very done, and you will see they are doing harm rather than cure the patient that we have. And to ensure that the patient arrives at the hospital very safely, but also timeline. Okay, not just having a patient in a health center and then to be referred the next day or when the weekend is over. At the scene, when you arrive exactly at the scene, not only for open fractures, but you have to look at to around, okay, especially because of these are patients who have been involved in road traffic injuries, and sometimes in the mining, sometimes in the houses fall. So you remove the hazard, you look at the mechanism of injury, and you have to protect yourself also, but protecting also the victim, not only yourself. And then you go to a little bit of the assessment. What is the problem? Is it the patient? Is it responsiveness? And you go to look at how you can transport also this patient. So why really the pre-hospital is very, very important? Probably there have been many studies around here, and in Rwanda now the improvement is really very nice when you compare with the SAMI that we have, and also the ill care, but always just to decrease the complication when the delays with the transfer is there, and the antibiotics, like Edward was just saying, to reduce the infection, a good sterility and the dressing, then proper sprinting and immobilization, very, very important, especially for this kind of patient, and also to decrease pain. Okay? Analgesics, timeline, and it will just help to transport this patient. At the site also, when you have this patient, especially it will be a polytrauma, a multiple trauma, hemodynamically unstable, then you communicate directly to the receiving facility from the scene. And when you are alive, it's not at the time you are alive that they are going to prepare to receive the patient. The readiness is really very important. So you ensure the safety before, like I was saying, even before the approaching the patient himself, for your safety, but also the safety of the patient. And you do a quick evaluation using ABCD. The ABCD, it's not only when the patient is in the hospital. The responsiveness of the patient is very important. But sometimes people are just misreaded with the open fractures, the bleeding, but they forgot that we are managing the whole patient. I can have a patient who is having a traumatic amputation, but at the same time also is having a tension in pneumothorax, where you are stopping the bleeding, already the patient has passed away. So, and you look at the signs of hemorrhage, and most of the time at the scene, in the hospital, you minimize the intervention. So you don't want to give all the care at the same time. You remember this is the patient that you are going to take at the nearest facility. So probably here I will not go all of through these initials, but like I was saying, you prioritize. You start by the thing that can kill the patient from A, B, C, D. And if your patient can't breathe very well, you have to give assistance breathing. And especially the ones that you find on the scene, they are in a coma with a GRAS score below of 8. You have to anticipate and intubate. Now the pre-hospital is really very advanced. All the so there's someone who is requesting it. Okay. So yeah, now it's really very improved. You have the monitors at the scene, especially with the SAMI, and you can just monitor the oxygen saturation continuously. So the circulation, you go to the circulation, and you identify the active breathing, and like Edward was saying, if you can't control the hemorrhage on the scene, you can use a tourniquet, especially a pre-manufactured, but also the manual one that you can have directly. And the most important thing here is also to start the resuscitation on the scene. And before even you transfer the patient, and you quickly assess the disability, you cover the patient to prevent hyperthermia, and always you avoid the prolonged on scene times. You are not going. It will take only between 5 and 10 minutes before you evacuate the patient. Then you assess the limb as much as the open fractures is concerned, and you document all the findings that you have directly. Because of the pre-hospital management, even the documentation is not done directly on the scene, but while you are transporting the patient from the scene to the hospital, it's where you have time to document, and to allow also the transmission report. So like sometimes on the scene, or during you are just transporting the patient, you can even take a photo of the wound if possible, and you avoid to manipulate always at the time the wounds before you arrive at the definitive care. The immobilization, you can use the pre-manufactured, you can use the local ones. All the time where you see some patients who come with the the wards, immobilize the wards. If you don't have them, even the carton, they can be used to immobilize the limb. The most important thing is to avoid the mobility at the level of the fracture itself, and also to allow easy ease of transport. The wound management, on the scene, you are not required to do anything much. But if there are much contamination, if someone has been trapped with many soils and what, you can just remove them before you apply any stride dressing. And you here, I can say that the most important thing is to cover and you don't close the wound. Because sometimes this patient can travel for long, 1 hour, 2 hours, 3 hours, and people are just standing even to suture the wounds before arriving at the definitive care. So now the pre-hospital management, they are really very quick and very trained. If it's a team of trained people, even they can install antibiotics directly, IV fluids, and during the transport, you can have the IV fluid, the antibiotics before arriving where the patient is going to be. As you know, if it's, Edward talked about it, the 60% of the infection are just decreased when it's given within less than 3 hours. And tetanus prophylaxis, this especially in the hospital, but when it's going to take long time during the transport, also can be given. The pain management very important, as you discussed very earlier. IV paracetamol if possible, and sometimes this patient can be even sedated. It depends if they are having really much in pain during the transport. So the transport, you have just to minimize the time on scene. When you are just talking all of this, you can think that will take the whole day, but it's really very quick, and you are going to bring the patient, to transfer the patient to the high level center which is available. It's not that you take the patient to the health center and this patient is going again to be transferred to the district hospital, So you have that to choose the center which is appropriate and which can manage this patient appropriately to avoid this kind of delays. And you monitor during the transport. You have to monitor the vitals. Not saying that I have already done it on the scene and then you stop by there. And you have to communicate with the area where you are going to take the patient, and they have to be prepared. It's not like you take the patient from the scene and you find when you are alive already at that center, there is a mass casualty already which is being received there. So you have to communicate. You communicate with the team and you take the patient where already they know and they are prepared. So you all the time you reassess the ABC during the transport. So the communication when you arrive at the hospital, you use this form of MIST, the mechanism of injury, the injury itself, from the time that you saw the patient, or what are the signs that the patient is having, but also the treatment that the patient has received. You can communicate verbally, but it's very nice also with the report that you can handle to the medical team when you are alive. Also, you document the sprint and dressing type that you have used, and always sometimes you can. These people are taking the patient from the scene to the hospital. They can mix patients, so you have 2 patients, and then always you have to make sure you identify the patient. Either you can write on his clothes, or you use a marker to identify the patient with the ID of the patient. You don't really mix the patient, and then you do a proper handover. So at the hospital, Dr. Edward has just talked about it, and then the care is going to continue. I will not go through all of this as we have discussed. So sometimes we have challenges like delay to presentation to hospital. You take the patient from the scene. Sometimes even they are just taken from the scene to home. Okay, the patient had an accident, and then the family is going to take the patient to home. Probably here it has been improved, but in the other African countries, they take even to traditional healers. So lack of EMAC and trained personnel, limited access to stress supply, antibiotics delays, under use of external fixation. So, and also, for task shifting protocol, very, very important also. So in summary, the infection, we just decreased almost 60%. And at the hospital, the external fixation can just reduce complication, and you are sure that the debridement is really done on timely. So these are the key takeaway. Do not cause the wound in the field. You avoid the transport in all of these things that we are doing. Always you have to remember the definitive management will be done at the hospital. And you use the context appropriate strategies that you have. If you don't have the appropriate equipment, you use the local one that you can have. And the training actually is very, very important because of the hospital is really very life-saving for life-saving in terms of the whole patient, but also to decrease the level of disability that this patient can have. So the communication is really very, very important. You communicate between where you have just seen the patient up to the level, to the center you are going to take the patient. So thank you very much. And if there will be any question or comment, is welcome.
I think we can take 5 minutes for questions as we transition. If that's okay. We're running a little bit behind. I think that's all right. Any questions for Dr. Allen?
Thank you. My name is Eric. I would like to know more about the use of external fixation, like which conditions you foresee such scenario.
This was just a global presentation. In some settings, you can just count the external fixation are not sufficient, and at the best injuries like it has to go through and the other, it has to be for the help of the wound, but also for stabilization and after the enlightenment. So you are sure that the center are going to take the patient, it's really very, very equipped. You understand? If you have a man with leg and then the right and you apply a cast or a string, now you understand the easy care how to be different. So yeah, like this case.
Yeah.
You have this and you have the right leg and you don't have an external fixation and you are going to take you are sure that the center you are going to take your patient is really equipped to
I think there were a lot of really important key teaching points from Dr. Allen's lecture. In the field, the most important thing that we're doing is saving lives, right? We're not trying to cure somebody's wound in the field, right? First thing, saving someone's life, airway, breathing, circulation, disability, exposure, the ABCDEs, right? That's the key. Save someone's life, stabilize them, get them to a healthcare facility, right? Then you're going to talk about saving a limb, right? That's what Dr. Rodriguez is talking about. Hemorrhage control, right? Putting on tourniquets, saving someone's life as well as saving someone's limb potentially, okay? Then it's all about open fracture management, infection prevention. Then we start talking about debridement and then stabilization of the skeleton, okay? So I think we can move on to the next lecture unless there are any other questions. Thank you, Joy.
Thank you very much.